Hello, good evening, everybody, and welcome to this evening's Facebook Live. My name is Alec. I'm the MD for Urology and Continence Care today. First and foremost, thank you very much for giving up your time. Just got a little bit of housekeeping before we start the event. As you can see, we are broadcasting from home this evening, so if you have any technical issues, just bear with us. My team in the background will sort those out. If you've got any questions, please do ask them in the chat panel, and one of my team will get back to you from there. The session this evening, kindly supported by Essity, is Understanding the Complexities of Continence Management in Dementia Care. And I'm very pleased to announce that we've got a new speaker this evening. We've got the wonderful Professor Graham Stokes, who's the Director of Memory Care Services, HC1, Honorary Visiting Professor of Person-Centered Dementia Care over at the University of Bradford. Graham, good evening.
Good evening, Alec.
How are you?
I'm very well, thank you.
And talking just before the event, very excited about this evening's session.
Immensely.
Brilliant. Before we start, I just want to say a huge thank you to Essity for supporting this event and the others that we've supported, or the others that they've supported throughout the year and last year. There's going to be some links towards the end of the presentation where you can pick up some free samples and contact Essity direct to get more information about some of the things that are going to be discussed throughout the presentation. So please do keep an eye out for those. As always, we'll have a live Q&A after the event between myself and Graham. So if you have any questions, either send them via direct message or into the chat box, and we'll get through as many of those as we possibly can. Links for certificates will be available at the end. Please enjoy the event. Please get comfortable. Without further ado, I'm going to hand you over to Graham, and I will catch up with you all after the presentation. Over to you, Graham.
Alec, thank you so much. Hello, everybody. Good evening. As Alec has said, we're going to be looking at the complexity of continence management when caring, supporting people who are living with dementia. So just to start with a few learning objectives, a fundamental one is establishing the difference, if there is one, between incontinence and inappropriate behavior. In the process, exploring the complexity of what we can call a toileting pathway, a pathway that I suspect everybody in this meeting takes for granted. But as we understand better the toileting pathway, probably appreciating differences between incontinence and inappropriate behavior, we'll identify ways to prevent, resolve, mitigate these toileting difficulties. And throughout, whatever I'm suggesting, recommending, the objective is also to preserve and protect the respect and dignity of people who are living with dementia. So if we start with what are the fundamental questions. The first one, is incontinence an early onset problem in dementia? In most cases, the answer is no. Second question, are toileting difficulties to be expected early in the process of dementia? And for many people, the answer is yes. So are these incompatible responses to the same question, or are we able to draw a distinction between what is a toileting difficulty and incontinence? And as we explore this probable distinction, we're going to be examining why a person with dementia may wet and soil in the wrong places. In the process, reveal that continence is a complex skill that is a challenge to be maintained when living with dementia. And if all we see is dementia, then maybe what we believe is that continence management is an insurmountable objective. We need to understand people who are living with dementia for who they are and appreciate why they do what they do. So that's a brief overview to this evening's session. If we start with terminology, I've obviously used this term a few times already. The term is a toileting difficulty. Now that's just a label. I'm using the term rather than label. Not incontinence. It's just, as I say, just a label, a toileting difficulty, but as labels go, it's a good one because it logically leads on to a next question, which is that beautiful question, why? If someone says so-and-so has a toileting difficulty, logically the response is why? Why have they got a toileting difficulty? And the explanation could be incontinence. because incontinence is not a description of somebody who wets and soils themselves, is a possible explanation, is a cause. If we say somebody's incontinent, what we're saying is they have damaged or lost control of bladder or bowel. And as we'll see, many people, the majority of people at certain points in the dementia journey are as continent as those who care for them, but they still will be having these toileting accidents and be wetting and soiling themselves in the process, especially wetting themselves. So we're starting with a label, a toileting difficulty, which leads to that logical next question, why? And the reason why that is so important is because we want to challenge the thinking that people wet and soil themselves for only one reason, and that is because they have dementia. If we believe that the explanation is solely because they have dementia, then we never ask the question why, because we already know it's because they have dementia. So we want to challenge people's thinking. So having come up with a label, we now define the label. So a definition of a toileting difficulty is the passing of urine or feces following either an unsuccessful effort or with no apparent attempt to employ an acceptable facility such as a toilet, commode, or urine bottle. Now, the reason why we need a definition is that once a team can agree on the definition of the label, then you can revert to the ease of using the label toileting difficulty. But we define it first so we know that everybody, when they use that term, understands why they're using it and the times that they should use it. So we have the term, we have the definition of that term, and then we want to put some richness into this. And that richness is actually to say, what are the characteristics of people who have a toileting difficulty? What do they end up doing? Now, there are several reasons why we want to pursue this precision in our thinking, and I'll come on to that shortly. But on the screen now, you should be seeing what are the most common characteristics that we observe when we say somebody has a toileting difficulty. And I've started with parcel. That's a strange behavior. People concealing wet clothes, wet bedding, soiled bedding, putting wet clothes under a chair, tucking the soiled bedding under the bed, or even doing such bizarre things as putting it in wardrobes, putting the soiled linen into drawers, leaving little gifts for their carers. It's offensive, it's disgusting. Now, surely this is a symptom of dementia. Well, we understand why people will act in such a way. It's because of embarrassment. It's the shame. It's what I've called pre-memorial experience. When you ask most people what their first memories are, most people say it's around the age of 4. So our earliest memories that we can recall are around that age. Some people say it's around when I was 3 or maybe 5. A few people say when they were 2 or when they were 6. But it clusters for most people around the age of 4. Before the age of 4, we have no or very little recall of any experience whatsoever, yet that was such a rich time of learning. I do not believe that many, if any, of us in this meeting can recall our toilet training. And that's because the vast majority of children in high-income countries are toilet trained before their 3rd birthday, in those pre-memorial years. So in other words, the value that we attach to toileting properly is not there for us to recall. It's what we call personal truth. We were toilet trained to toilet hygienically, privately, and with dignity, and it's at the core of who we are. If any of us are ever caught short, we never consider, well, shall I wet myself tonight? No, we're desperate to control our bladder. It's the truth that we hold. You do not disgrace yourself. So when a person who's living with dementia wets and soils themselves, it's hardly surprising that for some, they will try and conceal the evidence. So when we're considering this first outcome of a toileting difficulty, we're not talking about dementia. We're talking about the feelings of people. Then there's wetting or soiling clothes passive, while someone's sitting or in a chair or lying in a bed. Now, the explanation could be incontinence. They could have lost control of their bladder, and that's why they're wetting themselves. But is it because the person is clinically depressed? It's one of the most undiagnosed conditions in dementia. The person just cannot be bothered. It's all too much effort. So they've wet and soiled themselves where they sit or lie. Then there's wetting or soiling themselves while standing or walking. So they're active. So it's less likely to be depression. But is this because, for example, they can't find the toilet? And that may say far more about the building than it does about their inability to orientate themselves. Could it be a mobility problem, the so-called race between bladder and legs? So again, we start moving away from just saying this person's wet themselves because they have dementia, and we now start to appreciate the complexity. And then there is the case when people use inappropriate receptacles, fire buckets, sinks, waste bins, or men in particular urine up against a wall or a radiator, especially if it's white. Now, again, this could be because the person cannot cover the ground quickly enough and they have to use something. But could it be because of agnosia? Agnosia is defined as seeing without meaning, losing sense of truly what's around you. So you use what approximates to a toilet or a urinal. So it could be a sink or a bin or a radiator. And then smearing, truly objectionable. So surely at this point, we are talking about somebody who's presenting with nothing more than a symptom of a disease. Because if somebody smears, it's not that they're acting like in ways they've never done themselves before. They're acting in ways that place themselves outside the human constituency, because nobody smears feces. So surely this must be a symptom of pathology. Again, we can understand why. It tends to be associated with impaired bowel movements, diarrhea, constipation. So just imagine a person in their own home who's find their way to their own toilet. Their judgment is poor. They've got arthritic joints, maybe Parkinsonian tremor, maybe a bit of apraxia, whereby their movements are affected. The woman, let's say it's a woman who sits on the toilet, maybe her dress is all rocked up behind her, she's feeling uncomfortable, she's perched half on the seat, half off the seat, and she's trying to open her bowels. It's uncomfortable, and then she'll do something she will never have done before. With her poor reasoning, her impaired judgment, her hand goes behind her to find out why she feels so uncomfortable. Seconds later, her hand comes back out again and it's covered in feces. Pre-memorial truth, disgusting. And with her impaired judgment, she does her best. She flicks it, she wipes it down the wall, she uses paper, she wipes it on her clothes. 30 seconds after having investigated why she feels so uncomfortable, she's never done it. With her memory span, she can no longer remember for more than 30 seconds, for example. So as if for the first time, her hand will go behind her again to investigate why she feels so uncomfortable. When it reappears, again, there's feces on it. And once more, she'll flick it onto the floor. With her poor judgment, she'll wipe it down the wall, use toilet paper and scatter it around. 30 seconds later, she's never done it. Yet she still feels uncomfortable. So the whole process will repeat itself. As she exits the toilet, she's left behind a room smeared in feces. If a family member turns up, a home care worker turns up, it's objectionable, disgusting behavior. We need to show empathy to feel what this woman must have gone through as she tried to remedy the consequences of her own impaired actions. This is what I mean by establishing a picture of what somebody's doing when we say they have a toileting difficulty. Establishing the characteristics means we're acting in a very forensic way. And the technique is known as pinpointing. You're pinpointing precisely what somebody is doing. Now, as we pinpoint precisely by describing these characteristics, we reduce the likelihood of there being poor communication between team members, misunderstandings. But critically, the more forensic we are, the more detailed we are in our thinking, the more we start getting clues as to what might be happening. In other words, why are they acting the way they are? In other words, we're starting to move away from it's just because they have dementia. And we can aid this forensic way of thinking by placing our understanding of toileting on a pathway. Because we may be able to then establish where is the pathway actually breaking down. So the starting point of the pathway is we have to recognize the need to pass urine or feces and postpone for a certain amount of time the action of passing urine or feces. Now, if somebody cannot recognize the need or is unable to manage the urge, then that's incontinence. They have lost or are losing the control of their bladder or bowel. And that may be for a host of reasons, some of which may be quite localized, have nothing to do with the brain pathology, and can be remedied. So that's the starting point. Can somebody recognize the need? If they can, then they have to be motivated to do something about it. And as I've already said, maybe the person is clinically depressed. Everything is too much effort. And as a consequence, it doesn't matter to them whether they be wet or soiled. So are they living with undiagnosed and hence untreated depression? Now, if the person recognizes the need, can delay the action of passing urine or feces, and is motivated to do something about it, the next step has to be, can they stand? Can they get out of the bed? Can they get out of the chair? Have they got the physical strength and steadiness to stand? Now, that might say as much about the furniture that it does about their own immobility. Is the armchair just too comfortable, too soft that they can't lever themselves out? Is it impossible for them to step down from the bed? So it's a consideration of their physical status, but also the furnishings that they are living with. Now, just because a person has the strength and steadiness to stand, have they got the mobility and confidence to walk? Now, they might be able to walk, but how fast can they walk? And have they got the confidence? Because what do they see before them? For one thing, in a care setting, they're actually walking into the unknown, because the probability will be they just do not know where the toilet is. So they have to overcome their fear of walking into the unknown. As they walk, they'll have to overcome obstacles. It's not just the distance, but there'll be real or imagined obstacles. A long, shiny floor, looking wet and slippery to a pair of aged eyes. In a day centre, in a hospital, in a care home lounge, having to negotiate outstretched legs, bags on the floor, armchairs. So have they got the confidence and the ability to negotiate these obstacles? And of course, as you're negotiating these obstacles, it's slowing you down, which means you're less likely to get to that toilet in time. And then something that we rarely think about, the longer it's going to take from the person moving from their chair, for example, to the toilet, they have to hold that goal into their minds. And maybe they can't. If they have a memory span that's measured in just seconds, then maybe they cannot hold on to that goal. And that's not unique to people who live with dementia. How many of us have had that experience of dashing upstairs, getting to the top and thinking, what have I come up here for? Or walking into a room and thinking, well, I've come here for something. That's when we fail to maintain the goal. So critically, as the person walks, if they have a memory span that is measured in 30 seconds and the toilet is 31 seconds away, they'll forget where they're walking to. If they find the toilet, how easy have we made that for them? Is it the case that in a care home, it's nothing other than anonymous hallways, meaningless doors, uniform color schemes? Is that the challenge? Are toilets tucked away round corners? There's very poor visual access. So that will be a challenge. And then when they reach the toilet, what is it like? Is it safe, discreet, private, hygienic? I think storytelling often brings to life the challenges that people with dementia face. Mrs. S was one of the earliest women I worked with when we were starting to think very person-centered. And I always say that she did more for me than I ever did for her. She opened the eyes of so many of us. She like many people with dementia, not remarkable at all. An unremarkable woman living by herself, progressively dementing, becoming more at risk. 2 caring daughters, but both of them married with their own careers. So they're sort of semi-detached in their ability to care. And it was all getting too much. And so she was admitted into a care home. A woman who was admitted to a care home for reasons no other than she was becoming highly dependent. Within days, she became a very difficult woman for the carers to care for. It all coalesced around her refusal to use the toilet. I think more by luck than judgment, this care home that I think, if I remember rightly, 12 people lived in, had 3 communal toilets that are available to them. And they were just located outside the lounge. So you just walked out the lounge and there were the 3 toilets. And so Mrs. S would walk out of the lounge and she walked straight into the toilet. Logically, because she needed to use the toilet. And within seconds, she'd walk out. And then she'll be found minutes later in the hallway, in a bedroom, maybe back in the lounge, wet and soiled. She was labeled as deliberately incontinent, which is obviously a contradiction in terms. You cannot be deliberately incontinent. Deliberately wetting herself, even though she knew where the toilet was, that was true. She would walk in and she would walk out. So the next step for the carers was they would try to encourage her to stay in the toilet. And this is when it deteriorated. She'd become abusive. She'd swear. And this was so unlike her. Talking to her two caring daughters, one of whom I should say stopped visiting very early on, they would say, look, this isn't our mother, which is what you commonly hear when you hear about people with dementia becoming challenging to others. That's not my mother, that's not my husband, father, wife, etc. They take the evidence of their changed behavior as testimony to the fact that their loved one has disappeared. And that's why one daughter stopped visiting, because she was saying, that's not my mother. What's the point? The other daughter's hanging on by a thread. And as I got to know her better, she became more comfortable in talking to me. And she would talk about a woman who had standards. She was a real lady. She probably was quite self-centered, quite vain, and probably not the easiest woman to be with. Very self-centered. The way she was behaving now, deliberately wetting and soiling herself. And this one day I was talking to her, and she said, Graham, look, I've said numerous times, Mum was never easy, very self-centered. It was all about how she looked and how other people thought about her. It's all about appearances. And so this is why we know it's not her deliberately soiling herself. And then she just said, and because it wasn't just standards about her appearance, she had this thing about cleanliness. It was so much the case that she was concerned about hygiene, for example. It wasn't that she wouldn't just use a public lavatory. She wouldn't even use the toilet in the homes of friends and family. And that was the light bulb moment. What were we asking her to do? She was being true to herself. We were asking her to use what ostensibly were 3 public lavatories. And what she couldn't do is go up to a staff room and say, I'm sorry, I can't do this. I can't use a toilet that's shared with other people. Now, the challenge was what we're going to do. And that's what I mean when I say that she opened our eyes to the struggles of a person living with dementia. But what could we do for her? It was, none of the rooms were en suite. It was considered, might she be transferred to another care home, but it was thought that another change would be too distressing for her. So what we tried to do was to personalize, soften the fact they were institutional toilets, but what was maybe a softening to her was just clutter to another person with dementia. So they would just walk out taking the things that we'd put in to make the toilets feel more homely. We put in a seat dispenser where we could put a cover on the seat. And so if the staff were vigilant, they would get in there first and they'd put this seat cover on. And that did help, but it didn't resolve the distress. So as I say, we learned a lot from her, but I'm not sure that we did more than other maybe just bring tolerance into the attitudes of those who cared for her. But what I really struggled with was not just the challenge Mrs. S was presenting us with. I was really concerned about a door that I passed every time I visited the care home. And this door troubled me because on the door were 2 words, and those 2 words were staff toilet. What was wrong with the 3 toilets that the residents had to use, that the staff sought sanctuary in their own toilet? That was not about infection control. That was the fact that they didn't trust the cleanliness in the toilets that the people with dementia had to use. Now, my position is clear, that if a toilet isn't good enough for the people who work in the building, then they're not good enough for the people who live in the building. Why should people with dementia who have no insight into their condition have to make allowances when it comes to cleanliness and hygiene? Why not just remove the word staff and have 4 toilets used by everybody as a measure that we now are giving people living with dementia the level of hygiene and cleanliness they need? So Mrs. S was being true to herself. A small study that was conducted in Newcastle a few years ago showed the challenge, and I would say this study was done with women, we face when faced with communal toilets. Over 70% of women hover above a toilet seat because they don't want to make contact with it. Over 60% of women make little nests of toilet paper. And if you look at those figures, 61% are making little nests of toilet paper, but 73% are hovering. That means there are some women who are constructing these nests and then they hover above the nest. Over 80% of women are wiping the toilet seat before using. Over half of women avoid using the flush handle by using either paper or another part of their anatomy. When washing their hands, using wrists to turn taps on and off. And then nearly half of women in public lavatories leave the toilet without touching the door handle, which unfortunately does make me wonder, how do you get out? The public toilet concerns are about cleanliness, privacy, the whole atmosphere. Is it smelly? Is it cold? Is the floor littered with toilet paper? And the question for ourselves is, at what point in our lifespan do we cease to have these concerns? Next week? Next year? 5 years from now? 10 years from now? Or do we remain who we are? I believe we remain who we are. The challenge for a person living with dementia is then to survive in an environment where we're placing them in settings that always would have been a cause of concern for them. And that was the challenge for Mrs. S. And how many other people? There are over 300,000 people living with dementia in care homes. How many are having to face up to communal toileting? And that communal toileting may be extremely problematic, because who knows what may well have happened when the person before them has gone to that toilet, because that person is living with dementia, who will have impaired judgment, impaired reasoning. So who knows what state that toilet's in? So let's say we've achieved the ambition of providing toilets that are safe, private, hygienic. Then the person has to have the dexterity and coordination to adjust their clothing. Maybe an arthritic joint, a Parkinsonian tremor, apraxia will interfere with their ability to adjust their clothing. So once they're in the toilet, it doesn't mean all's well. And it may well be they've done literally everything. Remember how this journey and when it started? They've done everything. They've covered the ground. They've expended strength and stamina and speed. They've found the toilet. They're in the toilet. And at the very point that you think it's all going to be straightforward, and they just cannot adjust their clothing and they wet themselves. They exit the toilet with soiled clothing, and some bright spark says, look, he's incontinent. How dare we? And then let's say the person can arrange their clothing appropriately. They then have to initiate the act successfully, then they have to clean themselves up, and then they have to rearrange their clothing, all of which might be problematic for them. So even as the pathway comes to an end, the challenges remain. I think these levels of analysis, brainstorming, understanding what the possible causes are, bringing a pathway into place so we can truly get a sense of how complex successful toileting is. We can add to that by actually bringing to the forefront of our thinking true analysis. And sometimes we do this when we're working with people who are particularly challenging. Behavior analysis, often referred to as the ABC analysis, which will identify at what point in that toileting pathway are there problems. We know where they are. These are known as setting events. So when we say this person has toileting difficulty, what are we actually saying? Where does it happen? When does it happen? Who's around them when it happens? The so-called ABC, B being the behavior, A being the activating event, which triggers it, C being the consequences, the reactions. Behavior analysis answers the what, the where, the who, but what it does not do is answer the why. That's functional analysis. Functional analysis says, okay, we know what they're doing. We know where it is that they're doing it. We know when it happens. We know who may or may not be around them at the time. But why is it in that setting these behaviors occur? And the functional analysis looks at the person, it looks at an appreciation of their health, and it looks at the environment to get a true understanding of why. Up until probably 15 years ago, behavior analysis, function analysis were the ways that we work with challenges that people were finding distressing. But I'm also quite a fan of appreciative inquiry. Appreciative inquiry is quite refreshing. Behavior analysis, function analysis brings rigor to our understanding of the challenge, the distress. Appreciative inquiry doesn't even make reference to the challenge. Because even when somebody is said to be aggressive, they're not aggressive all the time with everybody. The ghastly old-fashioned word wandering. Why are they wandering? Well, even people who walk about a lot don't walk about all the time. Appreciative inquiry says, when are things working well? When is the person calm? When is the person happy? When is their behavior as it ought to be? Because if we can understand the reasons for the behavior that we want to see and the person wishes to have because they won't be distressed, if we can understand why that happens and get more, we can then get more of the behavior we wish rather than the behavior that we don't wish. So appreciative inquiry in terms of toileting would be, when are there no incidents of inappropriate behavior? And let's see what we can learn from that. So we have two ways of understanding. If we go down the path of it's working well, let's learn lessons. And the more we understand what the reasons are for it, everything being fine, we squeeze out the distress behavior. Or we truly understand through behavior analysis and function analysis what, where, why these behaviors happen, and then we act upon that. Using behavioral and function analysis, I want to talk about a gentleman called Mr. G. Mr. G was living in a care home. He was referred not because of his toileting. He was actually referred because of his violence, which was said to be unpredictable. So over a 2-week period, we conducted a behavioral analysis, establishing when he was violent, where he was violent, who he was being violent with. And what that revealed was he very rarely attacked residents or visitors. 95% of the assaults were against carers. And nearly 90% of those occasions is because the carers were intervening because of his toileting needs. He'd either wet himself and they were trying to ask him to come to his room to be changed. They were asking whether he needed the toilet, or they were trying to check as to whether he might have soiled himself. And then they were reacted to with violence. Now, this man was profoundly demented. His mini mental state examination score was only 7. He had the ability to understand far more than what he could say. This gentleman, spending his days sitting in a lounge, there was no way he could see where the toilets were because they were tucked away down the corridors. So they had very poor visual access. The environment didn't make sense to him. And he would, as the day progressed, wet and soil himself. The question was, even though he couldn't see the toilet, why did he not go up and try to search for the toilet? This takes us into who Mr. G is, the functional analysis. We start thinking, why is he acting the way he is? We know where he is when he wets himself. We know why he attacks people. But we need to know something about him. Mr. G was not an easy man. He was a retired teacher. He used to be, when he ended his career, he was a deputy headmaster. His wife told us he was a private man. He didn't have a sense of humor. He couldn't chat to anybody. He felt very ill at ease. In front of a classroom, a school assembly, he was fine. But he was not a sociable man. He was also a very stubborn man, and he was a very pompous man, full of his own sense of importance. And as we heard his story, we just built up an idea. This would not have been a man who in his life would have found it easy to go up to a stranger and say, "Do you know where the toilet is? Can you help me?" He was not a man who would have taken risks, the risk of making mistakes. So this man was not going to get out of his chair in the care home and start looking around for a toilet because he didn't know where he was. It was like he was just waiting for a mistake to happen. The one other thing that was positive about him, well, there were 2 positive things about him. One, he was a passionate gardener, an interest that appealed for his need for privacy. The other thing about him was His wife said to us, well, you might wonder why he wished to be a teacher if he wasn't a sociable man. And she said it was because he just liked seeing people learn. If he knew he was educating somebody to be better than who they were, then that was for him the reward of teaching. So that's what we knew about Mr. G. So we now put it all together, the behavioral analysis with the functional analysis. And what we concluded was that this man had two competing sets of needs. He had a need for hygiene, ingrained within us, personal truth. But that could only be met with assistance because there was no way how he could find the toilet by himself. But he also had a need for privacy and self-respect. If you tried to meet his need for hygiene, this would mean violating his need for privacy and self-respect. Somebody would be going up to him saying, Mr. G, would you like to go to the toilet? Do you want some assistance? If we met his need for privacy and self-respect, we were then going to violate his need for hygiene. So basically, the staff couldn't win. But we formulated an action plan based on our understanding of Mr. G. During the 2-week post-intervention period with the new care plan in place, there were just 6 episodes of violence, a dramatic reduction in violent episodes. We asked the staff, well, we obviously, because he was just sitting there, we couldn't actually preempt his wetting. We didn't know exactly when he was wetting himself. So on a rigid toileting plan, every 2.5 hours, he would be approached. But the word toilet was never mentioned. We appealed to the fact he was an educator, appealed to the fact that he wanted to be a person who helped others learn. And we appealed to his passion of being a gardener. The staff would ask him, could he offer them some help in the garden? Do the roses need pruning? The grass needs mowing, bugs needing exterminated. He would look, he would say nothing, and then invariably he would just stand up. And then the staff member would walk along the hallway with him, constantly reminding him that this was help that was needed. And as they passed the toilet, if it was a male carer, he would say, I'm just nipping in. Do you want to go to the toilet before we go in the garden? If it was a female carer, she would say, I've just been, what would you like to go? For a man who's a passionate gardener of his generation, who would be in the garden for hours, who would not wish to be caught short, this was a habit of a lifetime. In he would go. He could manage his own clothes. Addy would come. Now, he would have completely forgotten by this point the promise that had been made. But then you'd pick up the theme and into the garden you would go. And Mr. G would spend 5-10 minutes. It was a safe dementia sensory garden, so he could be left there by himself. He could be in the garden 5, 10, 15 minutes. And then he would resurface again in the lounge. 2.5, 3 hours later, he would be approached once more. Staff said, well, he'll work this out, but he couldn't. He couldn't remember from 1 minute to the next. That's how we brought down the episodes of violence whilst also promoting his need for continence. But there was a postscript. Happened 4 days into the intervention. I just by chance happened to be in the home. I saw a care worker talking to him and it was working really well. He stood up, they walked out together. And I was talking to the manager. And probably it wasn't even 5 minutes. And the carer returned, but with Mr. G. And I said, oh, he hasn't been long in the garden. And the carer said, oh, no, we didn't go in the garden. And I said, well, that's the care plan. And she said, no, but I haven't got time today. I've got something else to do. The home manager perceptively said to the carer, just look at Mr. G now and ask yourself the question. Over the next 5 or 10 minutes, is he going to enjoy himself as much sitting in the chair, in this lounge, as he would have been if you'd taken him into the garden? You see, the care worker had seen the garden as being the reward for going to the toilet. But of course it wasn't a reward. How can you reward somebody who cannot remember what they're being rewarded for? This was a care plan to promote hygiene and mitigate the number of violent incidents. But fundamentally, it was to improve his quality of life. Because people have to be given reasons to be alive. This isn't just a care plan to give people continence. It's to give somebody a meaningful life. It meant, you see, if he was being taken to the toilet maybe 4 times a day, that means that he was spending probably 3/4 of an hour of a day in the garden, improving his quality of life, meeting his need to be a passionate gardener once more. She never had too little time again to take him into the garden. And finally, I want to make reference to Jane, a toilet crawling with worms. Very similar to Mrs. S, she refused to use the toilet, but she wasn't abusive, aggressive. She became resistive, but it was founded on fear. You could tell this woman was frightened. She just would not walk into the toilet. She would just hold back. The staff had suggested continence pads, but she rejected them. She would pour them out and start to tear them and scatter them. So we conduct the functional analysis, looking at why might she be so scared of the toilet. She was an able woman, an elderly woman, but quite healthy. We did a neuropsychological assessment of her to really delve into the dementia, and we found she was agnosic. She was not seeing what we were seeing. She's seeing without meaning. It's not, the world isn't making the same sense to her as it does to us. We assessed the environment. You could not fault the staff. Caring, considerate, patient, tolerant, desperate to understand. Social environment, tick in the box. What about the physical environment? Well, the two toilets that were available to the residents were very institutional, very old-fashioned, very Spartan. And the toilet floors were black and white floor tiles, small black and white squares, like a checkerboard. So that was the physical environment she was having to encounter. This meant we needed to find out something about her as a person. We spoke to her husband, and as I've said already, once again, an unremarkable woman. The way we approach it is we just talk about her, and then we start talking about her living with dementia, and then we start talking about her living with dementia and the distress she now experiences. And we said to him, your wife, is she a nervy person? Because she's coming home as very frightened. He said, no, she's not an anxious woman at all. Just a normal everyday woman. And we're about to move off the topic. And he just said, well, she has got this silly thing about worms, snakes, hates them. She loves natural history. Never she was watching a TV program and a snake would slither across the screen. She would always avert her eyes. And we wondered, this lady who's agnosic, might she be misperceiving the black and white squares as black lines on a white background? And these black lines were being misperceived as worms, that the whole floor was vibrating, pulsating with worms. Not just her agnosia, but obviously a failure of reasoning, because a toilet does not have a floor pulsating in worms. So could it be that confronted by this anxiety-provoking environment, she was faced with a flight fight? She would flee, but if you hold her there, she would fight you off. So her agnosia was the reason why she was misinterpreting the lines, and her poor reasoning didn't come to her rescue. So while she was living with dementia, the primary cause of her behavior, her distress, was her fear of worms. Because if she was not fearful of worms, then she would not be acting the way she was, even though she was still dementing. So we carried out what is known as an ABAB research design, because we thought that if we could disguise the floor, and we were right, she'd walk across the floor. So the handyman in the care home said that he would need at least 2 covers of paint to disguise the floor. He used red because that was the only color he had. There was nothing significant about the color. And it took him 5 days to conceal the black and white floor tiles, which gave us the ABAB opportunity. Condition A is the non-intervention condition, and in the first non-intervention condition, that's the baseline. And you can see from the graph, in the 5 days, that she's been accompanied to a toilet that's not being disguised. She's having to face the black and white floor tiles. Each day she refused to cross the floor 7 to 8 times. Sorry, 6 to 7 times. Now we have the disguised toilet. So we now go to condition B, the intervention condition. She's now only going to be taken to the disguised toilet, and you can see immediately she crossed the floor. Only one time on average each day over those 5 days did she not cross the floor. I think the reason why there was this residual fear was because she'd built up a weak association with maybe the odor of the toilet or the sight of the toilet, and just by seeing the odor in the toilet, it generated some fear, but it's a weak association because throughout her life she'd never been frightened of toilets. After 5 days, you then revert to condition A. She's now going to be taken to one of the toilets that's not been disguised. She's going to be asked to cross the black and white floor tiles, and you can see immediately it spikes again. On average, 5 times a day, she's not crossing the toilet floor. Now, no one's being cruel at this point. She would then be taken to the toilet floor that has been adapted, and she had no problem at all. And then 5 days later, we only take her to the adapted toilet, and you can see she never refused. It was the toilet floor. I think quite rightly, people, when we first reported this, said it's the complexity of the floor covering. We know that people with dementia cannot cover easily pattern carpets. We tried over all sorts of pattern surfaces. She had no problem. Somebody said, well, maybe she's phobic about black and white floor tiles. And our response was, well, if that is the case, it's a little bit puzzling that her husband didn't know. So whilst we can never be arrogant and say we know what a person with dementia is thinking, I think what we can say is that it's a reasonable hypothesis. It definitely was the floor, and probably it was to do with her fear of worms. So I hope what this presentation has brought you is an understanding of the complexity, but I think of greater importance, it should resonate with the fact that we've talked very little about dementia as an explanation and a solution, and everything about a person. So that brings an end to this formal presentation. As Alex said at the very beginning, this presentation is supported by Essity, and so I'd like to thank them for that support. Essity have been working with HC1 for almost a decade, delivering training and support to promote excellence in continence and personal care needs. And so we're immensely grateful for that, but also our residents should be as well. And something I've been working with for many years now is the level of agitation amongst residents who are living with dementia. An example how we can resolve some of the reasons for the agitation is the Tenor shampoo cap. This has been part of the HC product formally since 2017. And we've conducted an evaluation in one of the homes. And this was in a home where there were residents who were unable to wash their hair normally. And this could be down to them being very agitated with water being poured over their head. And so as a consequence, we needed a solution. And the Tenor shampoo cap has shown to be that solution. Very easy to use, much quicker, far less intrusive. And it leaves the hair truly cleaned and refreshed. It also is helping residents to maintain their personal hygiene as well, when previously this was very difficult to meet. And this has been shown to reduce the workload attached to washing hair. So there are so many different ways of understanding the challenges and distress that people with dementia face, and this is one of the ways of addressing those challenges and coming up with a solution. So at this point, Alec, I'd like to hand back to you.
Thank you, Graham. The presentation is absolutely fascinating, and in particular for me, Jane's story was very moving. So thank you very much for the presentation, and thank you very much for joining us. With regard to the Tenor shampoo, Essity have very kindly said that they will supply anybody who would like a sample of the shampoo cap. With some samples there, you can contact your local representative via the email address, which is hcmarketing@essity.com. That should be in the text screen there, so you can just copy that. And if you want to obtain a Continence and Dementia Care digital resource pack, email them as well. If you don't have time to just pick up those links just now, we will be putting them on the presentation, which will go onto our website probably from tomorrow or Friday. So you'll be able to pick up all of these links if you do miss any of them today. And then before we get to the live Q&A, because we've had many questions come in, Graham. I think the subject is obviously one which is close to a lot of people's hearts. So there's a lot of interest in this. We just want to say that we're working with Essity to create a peer consensus about best practice. So we're basically trying to gain statements developed following a recent expert steering group, and we'd like you, the audience, to have your say and indicate if you agree or disagree with some of the statements. And this will be done via a survey, which is completely anonymous. It takes about 10 minutes, and again, the link to that should be in the chat box at the moment. But as we move on, if you don't get it, don't worry too much. We're going to put it up at the end, and we'll leave it with the presentation, which will be available after this evening's event. So Graham, if you're ready, we'll go straight onto the Q&A. And the first question, I'm not sure who this is from. This is from a direct message, but it says, have you found playing music in the background when performing personal care can help to reduce challenging behavior?
Yes. Music is probably the activity that engages people living with dementia more than any other. It only brings joy and comfort. It seems to be a way of distracting people. So by having so music can be very calming in the background, and that's good. But it can also be the case that if you've got somebody who has a problem because they are apraxic, which is the conscious control of movement, if their mind starts to shift on to listening to the music, then automatically they start to perform care actions that previously they were unable to do because they no longer are thinking about the care action. So the short answer is yes.
Okay, thank you very much. The second question is from Becky, and this is, do antidepressants have a good effect with patients with dementia?
Right, that's a very good question. The answer to that is they can. They have to be prescribed with great caution because of the risk of adverse side effects, because not only of the dementia, but of the person's age. But I think that we need to have also the awareness that an antidepressant will never resolve a person's depression. It tends to give you a window of opportunity. In essence, after several days, the antidepressant should help to lift the person's mood. And then you've probably got a number of weeks, no more than a number of weeks, to seize the opportunity that the person's mood has lifted, they're more flexible in their thinking, more positive in their outlook, more energetic. So something then has to happen, whether that be in inverted commas, the counseling, the talking, or whether it's enriching somebody's life. Something has to happen to hold that person in their state of improvement. If nothing happens and it's just the antidepressant, the window will close. And then I've lost count the number of times you see people who have been on antidepressants for months, even years, and the drug is doing no benefit whatsoever. So yes, they can have a positive effect. They have to be prescribed with caution, but something else has to happen as well in that person's life to improve their mood, and most definitely sustain that improvement in mood.
And would antidepressants then be a regular treatment for patients with dementia? Because I think could it be easy to think that somebody is depressed because of confusion and maybe anger, or is it a fairly standard?
Depression is notoriously underdiagnosed. It's often thought that depression is people who are living with dementia cannot get depressed because they can't think in such a way that they'll be starting to think themselves into a depressed state. It's not like that. It's the here and now. If
Graham has frozen on my screen, so if somebody could tell me whether that's me that has frozen, or whether that is Graham that has frozen. That would be good. He has frozen. There you go. I've just been told that Graham has frozen, so I'll just carry on until Graham gets back. I was very interested in that last question, so I was actually quite looking forward to what Graham has said. What will be interesting will be whether Graham actually realizes that he has frozen, or whether he's still talking to himself. So Graham is gone for now. Please do bear with us, though, because this should just be for a minute or so, and we've got plenty of questions, so please do keep them coming in. I'll take this opportunity while we're getting Graham back, to just say, again, thank you very much to Essity for supporting the event, and for every one of you who has joined us. This has been one of the largest events that we've ever had, with over 850 of you joining us. Your certificates for attending will be available to download. A link will be available through the chat screen once we finish. And on our website, which is Urology and Continence Care Today, it's ucc-today.com. Under the Facebook tab, from tomorrow, or possibly Friday morning, do keep an eye out. We'll be putting the slides from this evening, along with any links that we've mentioned, to get free samples and support from the concierge service over at Essity. And obviously, you'll be able to replay the video so you can share it with your colleagues. I think there's quite a lot of information in here which would be quite good for patients as well, sort of early onset patients that maybe they can watch. I think it'd be, personally, we wouldn't have any issue in if you wanted to share that with them. I'm just being told now that Graham is coming back. I wanted to touch my ear then, but I'm seeing it in front of me. It's absolutely not an earpiece. So Graham's coming back. We'll just wait for him to come back.
I'm back.
And, there you go. Graham's back. We were just
wondering. I have one wife, 3 children, and a cat to blame. So I'll find out later which one.
I heard the cat earlier, I'm sure.
Yes.
I did. I was.
That's right.
I was sort of giggling, thinking that that's a cat. I actually looked at the living room just in case it was there. Sorry, just to finish on that question, you were just saying that it's basically not a it's very difficult to tell whether somebody has depression from dementia, and so therefore it's not a standard treatment. It's not just a standard thing that you would give patients with dementia antidepressants. Is that's about right?
That's right. I mean, in Australia, people who are living with dementia who come into residential care, they're formally assessed as whether they may be depressed or not. In the UK, that's not the case. So there are many people with undiagnosed depression in care homes.
Okay, we're going to move on because obviously we've got lots of questions. I would like to get to them. The one thing I was just going to say before you came back is that we've got many more questions than we'll have time to be able to get through tonight. So as well as putting the presentation and the slides onto our website and onto the Facebook page, what we'll also do is we do keep notes of every single one of the questions that come in, and we will create a document with answers to those, and then we'll put those onto our website as well. So if we don't get through to your personal question this evening, we will get back to you at some point. So do bear with us. But for now, Graham, the next question is from a fantastic name, Genevieve. What a fantastic name. We don't see enough of those, I don't think. So Genevieve says, we have a patient with dementia asking for toilet every 2 minutes. We've got another 6 to 10 patients to look after. What's the best way to deal with this?
Right. I mean, obviously, the person doesn't need the toilet every few minutes. This is about insecurity. This is about reassurance. Obviously, I don't know how severe the person with dementia is. It could well be the case that this is an easy level possibility as a solution. If the person is there fretting about the toilet, you can actually write in front. You went to the toilet there's the time, and have a little clock. And so the person can see that they've went and this is the time. And then you can say, we'll be back to check on you at and whatever time that might be. Something maybe as reassuring as that. This is undeniably somebody who's insecure. Now, it may not be to do with the toilet. It may well be a way of bringing people to me. The only thing I can think of saying is, I need the toilet, where in fact, then asking for the toilet may be a way of saying, a metaphor for saying, please can you reassure me, sit with me, comfort me. So don't believe that. I often say if there's any group of people who mean what they don't say and say what they don't mean, it's people with dementia. So it may not be the toilet this person is asking for, but it may be. So it could be a very easy solution with a piece of paper and a clock, as I've said, or maybe it just needs a more thorough thinking through. And so my question would always be, if there are families still around, asking such things as, was he always an insecure person? Was he an anxious person? And then take it from there.
Yeah, thank you. I mean, I was thinking, actually, when I just read that question initially, I was thinking, maybe it's a staffing issue, but not really, because if the staff are able to handle that amount of patients, that amount of, I guess, I guess what I'm trying to say is my own question, I guess, which is, should there be what's the difference, or what should the difference be between the staff to patient ratio when you're dealing with patients who have dementia versus standard nursing care?
Right. I mean,
sorry, I know that I've thrown a bit of a curveball question of my own.
Well, it's funny enough that it's such a good question. It's something I've actually been dealing with today. It's almost impossible to answer because it depends on the caliber of the staffing, the competence, the experience of the staffing. It depends on the dependency levels of the resident. Now, is that straightforward dependency? I mean, for example, how long does it take to assist somebody with intimate care? Inim said, well, it should take no more than 20 minutes. The problem is the people who are living with dementia in care settings do not know they're living with dementia. They have no insight. So logically, what follows from there is they do not know they're in a care home. They do not know these people are carers. So then the question more pertinently is, how long will it take a stranger to remove the clothes of somebody who has no awareness they need to be cared for? And that's as long as a piece of string. You don't know. So is it just dependency, or is it behavior that's distressed as well? And then the final element is, sometimes you have buildings designed with wonderful visual access and you can see people. At other times, it's rooms tucked away. There are corners, etc., that you've got to negotiate. And so you can't see so much. And so when you start to say, well, should it be like one member of staff for every 3 residents or every 4 residents, and you start factoring everything else, it becomes virtually an impossible question to answer.
Yeah, maybe that's maybe that's a whole different presentation that we look at another time. So we've got another question. This one is, again, there's no name on this one, but it says, are there any simple changes to the home environment that could help reduce challenging behavior?
Yeah. Was that challenging behavior in general or relating to the toilet?
It doesn't say, but I would assume that it's toilet related based on obviously what we've been talking about this evening.
Right. In a lot of work that I'm doing at the moment, I'm actually turning the design of dementia care communities on its head. If you go into most dementia care communities, they're garish. Bright colors, primary colored doors, murals, signs, and it's just noise, because they were of their time. When you had a population of residents in care homes who were able to understand what a symbol of an armchair means, or a symbol of a plate and a knife and fork, and you had some ability to learn orientation, you can see where colors and symbols and signs played a role. Nowadays, it's just noise. Because it's not only the case that people with dementia cannot learn, so a red door is a red door and a blue door is a blue door, they can't reason. So a picture of an armchair doesn't mean to them, they're trying to tell me that behind that door there's a lounge. It's just a picture of an armchair, which they may not even be able to recognize if they're agnostic. So you turn it on its head and you strip out all of the noise and make them very calming environments, pastel shades, and the only door that needs to stand out prominently is a toilet door.
Yeah.
And when you then start to think, well, should you put a sign on it? If you're going to put a sign on it, the probability is the little man and woman figurine is what we're always used to looking for. And in dementia, what you learn last goes first. What you learn first stays the longest. What you've been accustomed to most also stays the longest. So why put a picture of a toilet? We don't look for pictures of toilets. If we're in airports, hotels, or restaurants, we're looking for the little figurines. So if you put the toilet door as a prominent color with a signage, and then ensure that the pathway, the physical pathway to the toilet is uncluttered, that it's not an obstacle course, and you become aware of such things as shiny floors. And so you've got an uncluttered pathway to a visible door with a sign on that might make sense. I think maybe one thing I would say, without violating people's dignity, if you know that people are wishing to be independent and will try and seek the toilet, if they can be sat as close to the toilet as possible, it means the journey is going to be of a shorter duration.
Yeah. Okay. Thank you. This is raising all sorts of questions for me that I'd love to chat to you about offline. But we've got one final question because we're running slightly over, but I know that everybody is still watching at the moment. So if you can just bear with us just for another 2 minutes, perhaps, while we ask this final question. And this is from Christian. And this is, how can we encourage client participation in the assessment and care planning process?
Again, a very good question. I think the journey of moving away from a disease model to a person-centered relationship model, and when you start talking then about people, then people have rights. It's not just about interests, and the right is to be empowered. Then I believe that we should always have a default position, is that we should try to involve people who live with dementia in their care plans. And that means pacing a conversation. It means moving away from just a verbal conversation and using, maybe, for example, pictures to enable someone to articulate as best they can. And so I think there are ways that we can enable a person with dementia to respond far better to questions about their care plan than we might imagine. I mean, we don't be unrealistic, but I do think a slowed patient response that isn't just based primarily on verbal communication does mean to say that you can get some meaningful information as to how that person would wish their needs to be met. And I think what you would then also bring into that equation is a true knowledge of the person. I mean, I said it in the presentation, we are who we are who we remain. The more we can be engaging with families who know somebody well, we should also be building a picture as to what they may or may not wish in a care plan. I'm very committed to what are called the I statements. I want. If somebody, we may have to sometimes use proxy I statements by going to somebody who knows them very well indeed. And I think also that carers, nurses can also be there as proxy in terms of observing. So you never stop an assessment, you're always assessing. And over time, just knowing somebody, you get a feel of what they want and what they don't want. So I think when you bring all that together, enabling somebody to be more communicative through different means, drawing on their family's knowledge of them over years, plus also always observing and learning, I think you then can engage somebody far better in their care plans.
Yeah, and I think that all makes absolute sense. Graham, we've come to the end. Can I just say I've genuinely found this a really, really fascinating subject, and I could sit and listen to for a very long time. And I'd love to catch up with you at some point away from this to have conversations around how we can potentially create some content for the audience, via our website, and perhaps some more of these events. So that would be amazing. To all of the people who are watching at home, thank you very much for the engagement. Thank you very much for giving up your evening. I hope you've all had some food and some refreshments while you've been watching. There's certainly been lots and lots of questions coming in. As I said earlier, if we didn't get to your question, we will create a document where we will list your questions with answers from us, from Graham, and from Essity. There should be some links coming up on your screen at the moment that show certificate, where you can get your certificate for your CPD files. Links to the things that I mentioned earlier, the free samples of the tenor head cap from Essity, so do that. Thank you very much to my team. Thank you very much to Essity for supporting the event. We'll be back for another event in, I don't know the exact date, but it's available on our website. So I'm just going to blag it and say that it's very, very soon. I do know that. I'm going to go and have my own dinner. So thank you very much, everyone. Good night and enjoy the rest of your evening.
Thank you, Alec.